Now we'll go to the next lecture in this session. Dr. Amit Mahadev, who doesn't need much of introduction for a person doing endoscopy. He is the chairman of BITS, Baldota Institute at Global Hospital, Mumbai. He is a doyen in endoscopy, therapeutic endoscopy, POEM, and pancreatic endotherapy. He is the world leader in this. He has done thousands of procedures, and he has trained hundreds of people, not only in India, but all across the world. He's a great teacher and one of the finest technician. His technique of endoscopy is really, really unique, and it's a pleasure to watch him doing scopies. So I'll invite Dr. Amit to give his talk.
Dr. Yogesh Shastri for asking me to talk to you today on difficult biliary cannulation tips and tricks during the 7th International Conference on Gastroenterology and Therapeutic GI Endoscopy. And needless to say, the ampulla of Vater, what I call as the elusive ampulla of Vater, is one of the most important hurdles for achieving an interventional ERCP, especially for a beginner. And as you can see here, the ampulla of Vater usually is having a completely different morphology in every subsequent patient that you see. And the ampulla is a very complex organ with multiple sphincters. As you can see here, you can have various muscle fibers of the duodenum itself and of the biliary as well as the pancreatic sphincter. And in addition, if you were to see the course of the bile duct as it comes down from the bile duct from the liver, the duodenum, and crossing across the ampulla, it is not a straight shape. It comes down vertically, then courses horizontally, and then again vertically as it opens on the ampullary orifice. Why? In the definition of a beginner who is doing ERCP, the ampulla of Vater is a small delicate organ situated in darkness and surrounded by vital structures. Dr. Peter Cotton had said that ERCP cannot be an easy procedure, and this was a classic definition he gave of ERCP, where he described it as 1% frustration, 2% radiation, 3% inspiration, and 99% perspiration, especially for those who are beginners. The traditional technique 30-40 years back of cannulating the bile duct was by using a normal ERCP catheter or a ERCP cannula. And that was the time when the technique was not an intentional technique, but rather an accidental technique where the cannulary tip was introduced into the orifice of the ampulla, and then by various directions, the cannula was pushed, and by chance, it used to enter inside the bile duct. However, such type of undirected technique using the normal cannula or the simple contrast injection and a cannula was invariably associated with either failure and its associated complications. Now, if you were to know why is it so difficult, is if you understand the ampullary anatomy and if you follow the proper technique, then this type of cannulation can be made relatively easy. So if you were to see, if you want to go across this S-shaped lower end of the bile duct, this can be described in 3 or 4 simple steps. The first step is after we have put the ampulla of Vater in front of us, in front of the lens of the duodenoscope or the ERCP scope, the first thing to do is to engage the tip of the instrument that you use inside the orifice. This is the step number 1. In step number 2, what we want to do is we want to straighten this S shape. So once the tip of the sphincterotome is engaged in the tip of the orifice of the ampulla, then the endoscope is pulled upwards so that the direction of cannulation becomes somewhere in towards this horizontal section. Now, once this is done, the third step is to bring the tip of the scope near the ampulla by moving the big wheel up, and at the same time, bringing the scope near the ampulla Vater. So if you follow these simple first 4 steps, then in a majority of the times, by using a curved instrument like the sphincterotome, you will be able to cannulate the bile duct selectively, and a deep cannulation can be achieved in majority of the times. You see here, this is the same way by using a simple sphincterotome without any other additional equipment. You put it inside the orifice and then you pull the scope backwards, turn the sphincterotome up, and then bring the big wheel of the scope near. And with this, you can achieve a selective cannulation of the CBD. However, in 5 to 15% of the times, cannulation of the bile duct can be difficult. And the definition of difficult biliary cannulation is if you were to keep on cannulating for more than 5 minutes, if you were to do more than 5 attempts, or if there is at least one pancreatic duct contrast injection. So this is presently the accepted definition of a difficult biliary cannulation. So what are the causes of difficult biliary cannulation? You can see here, first and foremost is the ampulla may be normal, but the technique can be faulty. And number two, and number three, and remaining are special situations. For example, you may have an ampulla which is low placed, or the opening of the ampulla is facing downwards and it is covered by a fold, or you may have an ampulla on the edge or inside a diverticulum. It is a possibility that the ampulla may be normal, but your guide wire repeatedly keeps on entering the pancreatic duct. You may have a deformed or edematous ampulla in case there is a malignancy just above it in the juxtapapillary region, or what we call periampullary tumors. This can cause lymphatic edema. Or you may have a normal ampulla, but all your techniques fail in spite of using the proper technique. You may also have a previously tampered ampulla where cannulation has been attempted or a cut has been attempted, which has distorted the anatomy. And finally, because of an altered anatomy, you may have an inaccessible ampulla. So for a normal looking ampulla of Vater nowadays, now it is considered that the guide wire or the glide wire cannulation technique is considered as the primary modality of cannulation. Now, in this case, what we tend to use is we use a J-tipped 032 glide wire, as you can see here, which can be rotated by the assistant, as you can see over here. And then the tip of the guide wire or the glide wire is engaged in the orifice of the ampulla of Vater. Then the sphincterotome is oriented towards the axis of the CBD, that is going from the right to the left, somewhere towards the 11 o'clock. And then the assistant starts rotating the glide wire, by which it passes through the S-shaped lower end of the bile duct, and you can achieve a selective biliary cannulation, as you can see what we did over here. You can see here that there have been 3 meta-analyses performed, which contain 5, 7, and 12 randomized controlled trials, which compare a contrast versus glide wire cannulation technique for selective bile duct cannulation. And the overall results of all these trials show that there is a much higher cannulation success rate when a guide wire or a glide wire assisted technique is used. So therefore, as a take-home message, the initial technique of cannulation should always be by using a glide wire or a guide wire instead of just directly contrast injection, which can be used only selectively in certain situations. You may have a condition where the ampulla is low placed or facing low down like this and covered by a fold. So by using the sphincterotome, you can lift the fold, identify the orifice. You can see that there is a small bulge, mucosal bulge. Then the sphincterotome is cannulated in the orifice. It is bent, by which you can lift, make the S-shaped portion straight, and then the wire is rotated, by which we can easily enter inside the bile duct. Or you may have a situation like this, where the ampulla is situated inside the diverticulum, and here the ampullary orifice is low placed. So now you have to drop the elevator, open the elevator, drop the sphincterotome, so that the tip of the sphincterotome can be engaged in the orifice of the ampulla. So now here now we are going to open the elevator, drop the sphincterotome, engage into the tip, engage into the orifice of the ampulla of Vater. And next thing to do is to lift it so that again the roof of the ampulla of Vater becomes straight, and then use the same technique of glide wire rotation, by which you can achieve a proper selective cannulation. What happens if the ampulla is inside a diverticulum and the orifice is facing towards one side? Then we use a technique which is called as a fulcrum technique. But here, instead of a sphincterotome, we use a straighter instrument like a simple cannula. So here, instead of just pushing the cannula inside the orifice, we gently push the cannula towards the orifice of the ampulla of Vater. Then the tip of the cannula is engaged in the orifice of the ampulla. Keep it there, and then gently rotate the small wheel to the right, by which you come into the right angle. And this way you can cannulate the bile duct selectively. All this is a very gentle and very small micro movement by which we can just rotate, come in the right axis, and then by a small push, our instrument can enter inside the bile duct selectively. What happens if our guide wire keeps on entering inside the pancreatic duct repeatedly? Then we use a technique which is called as a double guide wire technique. So here we leave the guide wire inside the pancreatic duct, and then by the side of this guide wire, now we are using a sphincterotome which is preloaded with another guide wire. And by using the same hand, we push the pancreatic guide wire a little down, by which the septum between the bile duct and the pancreatic duct is pushed away. And then we keep on cannulating somewhere towards the 11 o'clock or towards the left side of the pancreatic guide wire. You see here now that we are going on the left side of the pancreatic guide wire. Bend the sphincterotome so as to make the roof of the ampulla straightened, the S shape of the bile duct straightened, and then rotate the guide wire again. And you see here, by using this technique, invariably you can go inside the bile duct selectively. So now you have a guide wire placed in the pancreatic duct, one guide wire in the bile duct. We can complete the biliary endotherapy, and then over the pancreatic guide wire, we can place in a prophylactic pancreatic stent, which can be removed after a period of 1 week or 10 days. In case you have an ampulla which is located on the edge of a diverticulum and the ampulla is turned inside so that the orifice is facing inside the diverticulum, here we can use a very special technique. Here you can see that the ampulla is located on the edge, but it can't be seen. Only momentarily it is seen. So we can take the help of a baby biopsy forceps and catch one of the folds above the ampulla or by the side of the ampulla, push the ampulla out, and by the side of the baby biopsy forceps, now we are passing the sphincterotome along with the guide wire. And this way, by pushing it down, we can make the ampulla straighter and we can achieve a selective cannulation. The same thing is represented here, where the ampullary orifice is actually not even seen. So we are catching the fold on the side of the ampulla with a baby biopsy forceps, pushing it down, and by the side of that, now I'm using a cannula here, and here you can see this is the opening. So with the cannula now we go inside and we can go inside the bile duct selectively. So we have to maintain a steady pressure on the baby biopsy forceps, and then very gently, without pushing too much, we can enter inside the bile duct. What happens if all these normal techniques fail, the glide wire technique fails, and even if you have followed all the normal and the important steps of cannulation, then we can perform a very, very important technique, which is also called as the pre-cut sphincterotomy, which is actually a pre-cut accessotomy, where you de-roof the ampulla of Bader, intentionally expose the salmon pink epithelium of the bile duct, and then we can achieve a selective cannulation. This is one such example where we have attempted a CBD cannulation by using all the normal techniques. And after that, finally, we decided to perform a pre-cut sphincterotomy. So now to do that, we have to now take the needle knife. And you can see here that this is the orifice of the ampulla of Bader. So the pre-cut sphincterotomy is usually started from the orifice upwards towards the 11 o'clock. And layer by layer, as if you're performing a surgical incision, we are going to de-roof the ampulla of Bader. So you have to make sure that you use a movement by which is not zigzag. It has to be a straight movement. And then once we have cut the superficial layer, we take the knife back, and then by the sheath of the needle knife, we are pushing the layers away and looking at the structures which are below this layer. And then once we have identified the structure below this layer, you see where is the bulge. Usually the bulge indicates that is the course of the bile duct. So once again, we go from this orifice over here and again take the needle knife and do the next cut or the cut of the next layer because we have still not identified the salmon pink epithelium of the bile duct. So now what I'm going to do is this is going to be the axis where I'm going to keep on cutting. There is no point in cutting to the left because this will lead to a perforation. So we have to cut on the bulging portion. So now we are taking the knife out, and now slowly we extend this cut on the bulging portion a little bit more, and then we keep on sucking. And once again, by the sheath of this needle knife, we are going to separate the structures out and very carefully observe where the bile duct orifice is. Now you can very nicely see that somewhere over here is going to be the bile duct orifice. So now what we're going to do is that over here now we gently pass our instrument, and even if you do not use a guide wire, because now we can actually see the orifice of the bile duct, we can go in and selectively cannulate the bile duct. So this is the classical method how you should perform a pre-cut, where we can achieve a intentional cannulation of the bile duct in case of difficult cases, rather than performing a accidental cannulation by just pushing various instruments. So the pre-cut is an extremely useful technique for achieving a deep selective cannulation of the CBD in difficult situations, provided the ampullary anatomy is not too much distorted and you can make out the structures and the layers of the ampulla very well while performing the cut. In case you have got an ampulla which has been tampered with, previously cut, multiple attempts have been done at entry, and finally you have such type of a distorted, damaged, or destroyed ampulla waiter, where unnecessarily trying to attempt with a guide wire or a sphincterotome can further increase the edema and lead to complications. So in such a situation, we take the help of a EUS guided rendezvous technique. Now this is a relatively simple technique. So under endosonographic guidance, we identify the dilated CBD either in the duodenum, or we can even puncture the left hepatic duct, and then through the duodenum itself, we puncture the CBD and take a guide wire from above downwards. So here again, through the 19 gauge needle, which is passed through the EUS scope, after puncturing the CBD, once we have confirmed that we are inside the bile duct and fluoroscopy, we pass in a J-tipped Terumo guide wire and turn it downwards towards the ampulla vater. And then under X-ray control, we rotate this wire in such a way that it comes across the ampulla and is seen inside the duodenum. Now, once this wire is seen, then we can leave the wire inside or exchange this wire into a stiff wire, or leaving the same Terumo wire or the hydrophilic wire, we take out the EUS scope and pass inside a duodenoscope or ERCP scope. Now, once we see the wire, either we can catch the wire, pull it out through the channel of the ERCP scope and railroad a sphincterotome, or we can directly railroad the sphincterotome on the tip of the wire if it is seen very well. So here you can see now that we have got hold of the wire, we are pulling it back out, and then over that, we cannulate it further by using a sphincterotome and complete our therapy. So finally, just to tell you a practical algorithm for overcoming difficult bile duct cannulation, the practical tips and tricks. Initially, you should always start with a glide wire or a guide wire cannulation with a standard sphincterotome. In case the bile duct cannulation is difficult, and if you have not inserted a wire in the pancreatic duct, or if you have not gone in the PD number of times, then you can directly proceed with a needle knife pre-cutting technique by the technique which I have described to you. However, if there is an unintentional pancreatic guide wire insertion, then the best technique to follow is a double guide wire cannulation. Or if you're confident enough, you can do a transpancreatic pre-cut sphincterotomy and then directly enter inside the bile duct. Or you can place a pancreatic duct stent, and on the left side, you can do a needle knife sphincterotomy or a pre-cut. In spite of all this, if there is failed biliary access after initial ERCP, one good technique is to just wait for 1 or 2 days, call the patient back again and again attempt an ERCP, which invariably succeeds. If all these techniques fail, then out of all the techniques which are alternative, which have been mentioned below, one of the most useful techniques is the EUS guided biliary drainage technique. Either you can directly perform the therapy through EUS, or you can do a EUS guided rendezvous technique, where take the guide wire down, railroad your sphincterotome, and then complete your interventional therapy of the bile duct. Thank you so much for your attention.
Thank you, sir. Very excellent talk, as always, by the master. I want to ask your opinion about pancreatic septotomy. You know, most of the people who are doing ERCP, they are a little bit scared to do a pre-cut. If they fail, they keep on trying indefinitely. And even if the double guide wire technique fails, so and your wire has gone into the PD, and what's your take on the cutting on it, which is pancreatic septotomy? Is it safe, or can it be attempted?
Yeah, good question, Yogesh. And once more, congratulations for a fantastic conference which you have put up. And I personally don't follow the technique of transpancreatic pre-cut sphincterotomy. Though there have been papers which have shown that transpancreatic pre-cut sphincterotomy has shown to be having extra or even better success rates than a double guide wire technique. I personally have mastered, sort of try to master the technique and ask the trainees to master the technique of regular pre-cut. So what you can do is at the most place a pancreatic duct stent when you have placed a wire in the pancreatic duct, and on the left side of the pancreatic duct stent, you can perform a regular pre-cut sphincterotomy using a needle knife. That I personally feel is a very safe technique if you know how to perform the pre-cut well. So transpancreatic sphincterotomy is practiced by some endoscopists in the world. In fact, as I told you, there have been publications on it. But for a beginner, I will not advocate. You should learn and master the technique of regular pre-cut with a needle knife.
And how long one should like try for a cannulation before going
Pre-cut?
for pre-cut? Yeah.
I told you, so more than 5 attempts, 5 times you should try, or more than 5 or 10 minutes maximum, 5 minutes. Otherwise, what happens is you increase the chances of post-ERCP pancreatitis because of unnecessary traumatizing the ampulla as well as the pancreatic ductal epithelium. So it should not do that. More than 5 minutes if you don't succeed, and if you don't know how to do pre-cut, wait. Give the patient a gap for a couple of days unless it's a severe emergency. And after waiting many times, you will succeed. But it's important that you master the technique of pre-cut. It is not so difficult. It is unnecessarily, there's a hype that pre-cut is dangerous. Pre-cut is dangerous only if it is not done in a proper way or if it is done too late. But if you do it within time, pre-cut is a very, very useful technique.
And what is the setting advice for pre-cut, sir? Because if you keep a coagulation little higher, then
Yes.
there's a charring, and then you don't, the visibility is less.
Agreed. Actually, for pre-cut, we use the same setting as a normal sphincterotomy. On a Urbe cautery, we use the same endocut cube. So if you use the normal endocut cube, which has been advocated for a sphincterotomy procedure, the same current settings can be used. There is no need to use a pure cutting. We can use it with a combination.